We thought we would talk about wheeze for the next 20 minutes or so, if that's okay, because I think that's the most common pediatric presentation that we see, but super happy to talk about other things afterwards. Basically, I think the most common issue that we see in the management of wheeze is clarity of definition. So I just want to spend just a second just clarifying what we mean about the difference between bronchiolitis, preschool wheeze, or reactive airways disease, pneumonitis, and asthma, because honestly, I think that's the biggest thing that we get in knots. And I just want to share a bit of a conceptual model of those, how I think about them, and a little bit of the treatment options that we have for those things. So I think of these really as a continuum of disease that work in three different age groups. There's the under 1-year-olds, and in under 1-year-olds with wheeze, I would call that bronchiolitis. There's the school age kids, so 5 years and above, and anything over 5, I would be pretty comfortable calling asthma and managing with asthma type medications. Anything between 12 months and 5 years is where it gets a little bit grey, I think, and we get these kind of overlapping diagnoses of, is it reactive airways, is it pneumonitis, is it other things? So I want to think about those in just separate categories, because I think that affects the treatments that we use and what's likely to be effective. So I want to share a bit of a conceptual model. This is way too crude to be real histology, but this is kind of how I think of an airway. I think of an airway as having 2 layers to it. And wheeze is just caused by a narrowing of the bronchiole, so a narrowing of that particular piece of the airway. If you take a cross-section of a bronchiole, they've got 2 layers. They've got an outer layer, which is essentially muscle, and they've got an inner layer, which is essentially epithelium. You can, I suspect professors of pathology at medical school would be quite upset with that definition, but conceptually it works for me, and I think it works in the way that we think about treatment. So when we think about bronchiolitis in kids who are under 12 months old, most of the problem here is swelling of the epithelium. There's been a bit of debate about whether kids under 12 months old have beta receptors in their smooth muscle and stuff like that. I think we've pretty definitively demonstrated that they do, but what they don't have is just very much smooth muscle at all, because we develop most of the smooth muscle in our airways from about 12 months onwards over the next, up to about 24 and a bit more months beyond that. But basically under 12 months, there's very, very little smooth muscle in the airway. So that means that the pathology that you're actually treating when you're seeing a wheezy kid is swelling of the epithelium. And that means that things like bronchodilators and other medications that work on smooth muscle just aren't going to work because there isn't enough muscle to interact with. Now, bronchiolitis is the most common reason, I think, that we would see a patient in the pediatric emergency department. Quite excitingly, there is, many respiratory viruses can cause this. RSV is probably number 1 at most times of year, though of course it does go in waves. And quite excitingly, there's a vaccine for this, which is going to make its way into Australian circulation fairly shortly, and it will be really exciting to see what that does to the numbers of babies that we see with bronchiolitis. I think that's yet to be determined. So there's because it's the most common thing that we see in pediatric emergency, there's quite a lot of evidence, and quite a lot of good evidence actually, about how we manage bronchiolitis and what works. And sort of the short answer and bad news really is that essentially nothing works. There is a document that if you're interested in a little bit of further reading, I'd really recommend the PREDICT guidelines. So PREDICT's the Pediatric Emergency Research Network in Australia. And they did really what is the most comprehensive evidence-based guideline on bronchiolitis that's ever been written. It's up for review again the next couple of years. It's probably written about 4 years ago now, I think. But they basically broke it all down into all the treatments that people use and all the things that we can do, and then did a real deep dive on the literature of what they could demonstrate works and what didn't, and came up with this great document that's 250 pages long or something, but it's got a summary document that is about 6 pages long. So if you want a quick snapshot, that's really well written. Essentially what they showed is that nothing works for bronchiolitis. Specifically, the things that don't work for bronchiolitis is that chest x-rays don't change practice. In fact, if we do a chest x-ray, interestingly, we're more likely to prescribe antibiotics than if we don't do a chest x-ray. but it doesn't actually make any difference to the prognosis. So for straightforward bronchiolitis, we shouldn't be getting a chest X-ray. Adrenaline nebulizers don't work, or adrenaline in any form doesn't work for bronchiolitis. Steroids don't work for bronchiolitis, and perhaps the most controversial of all of them is salbutamol. And a lot of pediatricians still don't believe this, actually, but there's pretty reasonable, robust evidence that salbutamol under 12 months old for wheeze does not work, does not have any effect. A lot of pediatricians will still try it from, some people argue 6 months, some people argue a little bit older than that. My take with our registrars is that if babies are getting close to 12 months and they really want to know if it's working, they really want to try it, then they've just got to have a really objective assessment of whether it's working or not. So they've got to know what the respiratory rate is with the child at rest before they give the salbutamol, and they've got to know what the respiratory rate is afterwards. They've got to know what the work of breathing looks like, both themselves and what the parent's perception of the work of breathing is. And if there are changes in either of those two things, then I am pretty happy for them to try that. I'll come to the questions at the end, actually, because I will get distracted. But Helen, don't let me forget, because that's a good question. So salbutamol. So is it worth trying? It might be fair to try it a little bit below 12 months, but don't expect it to work. Because I think one of the traps that we walk into, one of the traps that I walk into actually with wheezy kids, is that I start them on some bronchodilator treatment and I walk away, expecting that they will look better in 30 minutes time, which they usually do in truth. That is clearly a trap for lots of reasons, but if the kid is under 12 months old, don't expect them to look better, because it probably won't work. The other thing that we use quite a lot of in bronchiolitis is high flow, or nasal high flow. And this is, I think this is actually a piece of marketing genius by Fisher and Paykel, because if you sort of go back far enough to where it started, like the real big study that got it started was one that was done in Brisbane in ICU, where they showed a really dramatic reduction in the rates of intubation in babies that were treated with nasal high flow. That was done in the context of PICUs around Australia that have very different rates of intubation in kids. So it's quite possible that we just put kids on high flow in Brisbane, and that made us a bit more comfortable to watch them for a while, whereas the decision to intubate them was subjective, basically. So whether we actually change the pathology or not, nobody really knows. High flow's crept into really quite wide use now, and there's one study that I think is worth knowing about, that I kind of consider this the study that, it's a bit of a miracle, really, in that it is a study that didn't really show anything, but it completely changed practice across a lot of what we do, certainly with kids with bronchiolitis, and that was Paris, so the original Paris study. So what they did was randomize kids to either kids with bronchiolitis, so kids that were under 12 months old, and importantly, and this is really key, I think, kids that were hypoxic. So they had to have SATs of less than 92 or less than 94%, depending on which state you were randomized in for various reasons. But the key is they were hypoxic. They randomized them to either low flow oxygen or to nasal high flow. And what they showed was that they had a number needed to treat of 9, essentially, of kids not getting an early warning score that went above a certain level, so not getting vital signs that were particularly out of whack. So what they essentially did with Paris was drew a line in the sand that was completely arbitrary in terms of vital signs, and said that if we start you on nasal high flow, then 1 in 9 of you will stay on this side of this arbitrary line that we've drawn. So there's a benefit. That was the take-home message. On a system level, that makes an enormous difference, because the numbers of vital signs that they'd chosen were ones that tend to trigger MET calls and escalations and things like that. So actually they showed that we've got a 1 in 9 chance of making you less likely to trigger a MET call, less likely to need to go to PICU. So on a system level, it makes quite a compelling argument to use it in the appropriate set of kids, of course. There was not a patient comfort group. I think anecdotally, some kids it really pisses off and it's just not worth persisting with. Some kids actually tolerate it, settle down, and it works quite well. So an N of 1 trial with nasal high flow, I think, is fairly reasonable in most contexts. There is a study going on at the moment that's seeing if we can reduce retrieval rates from rural contexts, particularly by using nasal high flow to keep those numbers within within acceptable parameters. What they also showed with Paris was that it was safe. There were no increased complication rates with high flow, as long as they stayed within certain parameters. So that meant you could nurse them 1 to 4, which made a big difference to flow around hospitals. The key with nasal high flow, though, is that you do see different things with different numbers and different flow rates, but high flow is basically 2 litres. 2 litres per kilo per minute came from the inspiratory flow loop. So if we map how fast a baby can breathe, 2 litres per kilo per minute is about how quickly they can breathe in. So that's how they chose that number, 2 litres per kilo of flow, and then they titrated oxygen saturation. And if you needed a fraction of inspired oxygen that was less than 0.4 in Paris, then you could stay being nursed on a ward. As soon as your FiO2 went above 0.4, you needed to be moved to PICU. So there's some really good, I think they are lines in the sand and they are a bit arbitrary, but there's some good parameters when we're using high flow to sort of say, actually, if we go stay below 2 litres per kilo or stay at 2 litres per kilo per minute and keep an FiO2 below 0.4, then we're okay to stay being nursed on a ward without any great increased risk of complications. The other thing that's important with high flow, of course, is that little babies get a nasogastric tube, because otherwise their stomachs fill up. And it compromises their room to actually breathe. Tony, can I ask you, for looking after babies with high flow, what adjunctive trip, what supportive things do you do with them? Not just with high flow, sorry, but with bronchiolitis. What supportive things can you do with kids under 12 months old to make them more comfortable?
A lot of it, like what you were saying earlier, like, a lot of treatments, don't work for bronchiolitis. The things that really beneficial are, well, firstly, like most babies are obligatory nose breathers. So if they've got a nose full of mucus and plugging up, they're going to really struggle. So that'll increase their work of breathing. It'll decrease how much gas or air is flowing through the nares. So keeping the nares really clear is really important. So some sort of gentle nasal suction, if they're really quite blocked up, it is worthwhile doing. It's a bit of a trade-off because it's usually quite distressing to the baby. So they will get sort of distressed and it'll make the work harder and look sort of a little bit worse in the initial sort of phase. However, if they are constantly blocked with a blocked nose, they're going to struggle continuously until that nose is blocked. I'd recommend, so in an ICU, we'd do some sort of fairly deep nasal suction, like nasopharyngeal suction with like a Y suction catheter. But there's risk associated with that, with deep sort of pharyngeal suction, because you can sort of trigger like a vagal bradycardia and things like that. So I probably wouldn't recommend that so much, but just using sort of the Y piece of a Y suction catheter and including the long sort of part of the catheter and putting that into the nair. And if it's really thick mucus, perhaps a couple of drops of saline up the nose as well. And that'll help to clear that out. And that'll make an enormous difference to the actual work of breathing. The other things are around just sort of comfort. So these babies with bronchiolitis, they feel miserable. The treatment really is rest and recuperation as much as anything. So paracetamol just to keep them comfortable. Wrapping babies is really worthwhile. It's probably a big change that I've, one of the bigger changes to my practice. Babies that are generally like to sort of be wrapped. You don't want to wrap them too tightly so that they're sort of really trapped. But containing the arms is a big point. So what you'll find is kids like this are quite restless. They'll turn their head from side to side a lot. They'll wave their arms around. If you can kind of contain that sort of stuff, the babies will tend to settle. Yeah, so that's really important. So ultimately what we want to do is just have these babies sleep. So sort of swaddling them is important. Positioning is really important. You want them in a sort of nice sort of neutral position, and do everything you can just to get them to settle and sleep. So that means sort of quite a calm approach from the parents and the staff around them. Parents are great, so they're a really useful tool. Get the parents to hold the baby if it's necessary. Nice pats, nice firm pats in the bum. All these just little sort of tips make a really big difference in just getting the baby to settle. And once the baby's settled, that's your goal. So these sort of things will really reduce the amount of effort that the baby's expending, So because when they run into trouble, it's when they become physically exhausted, like their respiratory muscles, they actually start to fatigue and they can no longer keep it up. So all the times you can minimize crying, screaming, things like that, yeah, they're all worthwhile things to do. Um, uh, Comfort feeds are worthwhile. So quite often, as a child gets sicker, you don't want to feed them large amounts of feed. Same as like having sort of, a stomach full of air, stomach full of food, makes it a little bit harder for the diaphragm to breathe against the full stomach. So small feeds, just sort of perhaps a bit more frequently, because you don't want them starving and hungry and screaming, because again, that's going to distress them, make them cry a lot. But also you don't want them to be, have a big full stomach as well. So it's quite a few little sort of simple things like that. The other thing is just around some monitoring. So just when you put your SATS probe on, so I've seen a lot of times people, when the SATS probe's on, it's not perhaps the most secure, it doesn't give you the best reading. And then when you start to get sort of error readings or low saturations because of a poor trace, people start becoming anxious that's actually that the child is desaturating. And all that sort of leads to is more sort of prodding and poking and assessing and whatnot, and it interrupts all that sort of rest state. So they're just a few sort of little things that you can do just to keep the baby sort of settled and calm, and they're really that's the crux of the treatment. In addition to things like hypo and that, but just it's simple, the most basic nursing stuff, but done really well with a lot of attention to detail. And that's what'll benefit these babies the most. Yeah.
I think that's awesome. Thanks, Tony. I think that contrast actually sums it up quite well, doesn't it? Where all of the medicines that we use basically don't work for bronchiolitis, but all of those pro tips for positioning care that you talk about, that actually that's the most effective things we can do. All we can really do is support their breathing, support their feeding, and do all those adjunctive things that Tony mentioned. So that's beautiful. Thank you. So I just want to contrast that. So it's bronchiolitis, basically. We're going to support their breathing. I want to contrast that with asthma, and I kind of think of this as sort of the other way around with that conceptual model. So this is kids that are over 5 years old, and we can talk a bit about the definition of asthma if you like. But certainly kids over 5 years old are worth thinking about like this, where they've got actually a small layer, or relatively smaller layer of epithelium, or smaller contribution from epithelial edema, and they've got a bigger contribution from bronchospasm. So their biggest problem is muscles. So what we've got to do is try and relax the respiratory smooth muscle. And there are sort of some basic standards, I guess, that we use to do that. The reality is the guidelines differ between every country in the world, really, which kind of shows you how well we really understand the evidence for what works. But in Australia, salbutamol, as you would be familiar with, salbutamol, we use 3 lots of 6 or 12 puffs, depending on the weight of the child, and then reassess unless they're critically unwell. Spacers, obviously, or an inhaler with a spacer is obviously the ideal way to deliver Ventolin, and that's better than a nebulizer. There's a couple of reasons for that, but the most significant reason why that's preferred is the place in your respiratory tree that the drug is dropped effectively depends on the particle size that it's delivered in through it when you're giving an inhaled drug. With a spacer, with an inhaler with a spacer, it gives a very controlled particle size, so a lot of the drug gets deposited in the appropriate part of the respiratory tree. If we're using nebulizers, then the size of the droplets actually depends on the flow rate of the oxygen. So nebulizers have got to run about 8 liters a minute, and that they're a little bit less accurate with where they'll deliver salbutamol to. So spacers is ideal. Anybody with moderate asthma or beyond, adding atrovent ripratropium to salbutamol, particularly for that first burst, does improve things. So Cochrane review says moderate or severe asthma will benefit from ipratropium. Mild asthma will not. How you define moderate versus mild asthma is a bit of a subjective choice that is up for debate. So in truth, if a kid's in hospital and working hard and you're looking at them thinking, you don't look quite right, if you add atrovent ripratropium, either in inhaler form or in nebulizer form, it's pretty hard to criticize is the bottom line, I think, with that. Once kids have not responded to repeated doses of salbutamol, my thresholds actually for using nebulizers versus inhalers are pretty crude. To me, if kids are like they've got SATs less than 90 and I actually want to have them on oxygen, then I tend to use nebulizers, and I tend to add some Atrovent to that. But that's not a hardcore scientific argument. That's really just pragmatic. Kids that are over 5 who have responded to some form of bronchodilator, they should basically all get steroid. The traditional choice for that has been prednisolone. It was 1 milligram per kilogram or 2 milligrams per kilogram for the first dose, depending on which state you were in, which again says something to how well we actually understand what the real answer is. But I think it's now a pretty well accepted alternative to use dexamethasone instead. So 0.3 milligrams per kilogram of dexamethasone instead of prednisolone is part of the Royal Children's Hospital guideline now and has been used overseas for quite some time now. And the real pragmatic advantage of that, to me, as an emergency physician, is that I don't have to send people home with a script. If I give them a single dose of Dex, that's fine. They don't need a follow-up script of prednisone for the next few days. So I like that. I think it's practically helpful. If the salbutamol's not been sufficient, and steroids are going to take a while to work, bear in mind, but if the salbutamol's not been sufficient and the kid's still working hard to breathe, that's when IV bronchodilators are the next thing in line. Well, you've got two options here. If you're in somewhere where you can't get IV access, and a kid's got severe asthma, then IM adrenaline is the next option. And to be honest, we were discussing this earlier, and we'll maybe talk about it a bit more later, but I'm pretty comfortable with people using adrenaline in this context if you're really worried about a kid's breathing. Because I think, and this is not evidence-based, but I think that the real life-threatening asthmas that we see, I think a number of those are single system anaphylaxis that we've misdiagnosed. So I really have no problem with kids being treated with IV adrenaline if people are worried and can't get IV access. Sorry, IM adrenaline if people are worried and can't get IV access. Traditional choices of bronchodilators intravenously, you've got 3 really. You've got magnesium, aminophylline, and salbutamol. And I think what we have discovered from researching this is that essentially which one you get depends on where in the world you live, because the guidelines, again, vary enormously in terms of dose, in terms of timing, in terms of indication, and in terms of which order we use those medications in. I think most of us in Australia lean towards magnesium first. Certainly I do. And the reason I like magnesium first is I think there's the strongest evidence for it. Again, the evidence is not strong, but there is one meta-analysis of 6 studies that, again, using different doses that suggests it's helpful. Also, the side effect profile of it, I think, is the most benign. Aminophylline tends to make people puke, but if you're really struggling, aminophyline's fair. And intravenous salbutamol, I'm not sure what the advantage of that on the top of continuous nebulized salbutamol is. But again, certainly something that's reasonable to consider. Tony, did you want to say anything about asthma or giving nebulizers particularly to?
So again, probably, if you look at the basics, positioning is really, really important. So sit patients up, and I think that's a well-worn path. People are very familiar with that. But my experience is that we see so frequently that people have position the child up initially, but as a child, they don't sort of stay there. They slump down and whatnot. And quite often we'll sort of when we've gone to both when I worked as one of the Met nurses in the Women's and Children's Hospital here in Adelaide, and on retrieval, we'll frequently sort of meet a child that's laying sort of flat or scrunched up in the bed. So the part about sort of the positioning is positioning them upright, and then reposition them every time they sort of slump, because it makes a really enormous difference. And that positioning also is you want to sort of avoid that sort of slouch position. So they might be upright, but in that sort of crook of the bed. So you want them sort of really propped up, opening up the chest, perhaps even leaning forward. If you can lean them forward over a pillow, simple things like that will make actually a really, really big difference. I think as asthma gets worse and more severe, probably the other couple of tools in the arsenal, and it's not an easy thing to do, but masks, like non-invasive CPAP is another tool. Certainly well understood that if you ever had to intubate a child for asthma, which in itself is quite a life-threatening treatment, that the PEEP is because there's a lot of gas trapping within the lungs. You want to avoid any sort of PEEP on positive pressure ventilation. However, if they are self-ventilating, mask CPAP can actually be really quite beneficial. So it doesn't have that sort of intrinsic PEEP isn't such a big deal if they are self-ventilating. But that's we're talking about really very, very severe asthma now, and now this is getting to the point where they're getting closer to being sort of peri-arrest. So it's further down the track, and you also need to have the equipment available to do that. But certainly something that's always in my mind. That is my sort of next escalation once we've run out of drug therapy, and because we want to avoid intubation at all costs, unless you just have no choice. That would be the sort of next one, and it's fortunately it's not something we have to do a lot, but that's probably the next sort of part of the equation for me. Yeah.
Awesome. Thanks, Tony. I'm conscious that I've talked for longer than I'm supposed to, but I just want to mention just this group in the middle as well, these kids with what we call reactive airways disease or pneumonitis. And truly, I think these are a bit of a trade-off. So these are the kids that are over 12 months old and under 5 years old, so that toddler preschool age group. And in truth, they've got a mixture of the two, really. They've got some epithelial swelling. They've got some smooth muscle there that's reacting as well. So we can use asthma medications in this group, and we often do, but we kind of got to use them experimentally because they may respond to nothing but oxygen. They may behave like a kid with bronchiolitis, in which case we tend to call them pneumonitic, or they may behave a little bit more like a kid with asthma, and they may respond to bronchodilators, in which case we tend to call them reactive airways disease. But these are kind of overlapping diagnoses, and really the only way to unpick these, I think, is to use some bronchodilators, particularly Ventolin in decent doses, but have a really good objective idea of what the kid looks like beforehand in terms of their respiratory rate and their work, and then again afterwards in terms of their respiratory rate and their work. And if you're finding that you're winning, keep going and give more. And if you're finding it's not making any difference, then you may need to just back off and treat them more like a bronchiolitic kid. But that's a bit of an overlapping fudge. So they're the messages I want to get across, basically. Kids under 12 months old, supportive treatment only. Kids over 5 years old, hit them hard with the asthma treatment. Kids in between, you may have to do a little bit of trial and error of both. And we might stop there and have a think about a case, and I'm really happy to also to answer any questions, of course. So thank you very much. If I can end that. Yeah. Are you back in charge now, Helen? Have I got that right?
Yes, I am now back in charge. Thank you.
Wonderful. Thank you.
So I'll just pause that and we can go to the